Hello everyone. Today I discuss the second part of the gingival recession, which is the surgical management using pedicle graft. In part 1 we discussed the etiology and non-surgical management, but in this part we aim to discuss the use of pedicle soft tissue graft in the treatment of gingival recession. As we know, gingival recession is defined as the apical migration of the gingival margin from the cemento-enamel junction downwards. Periodontal plastic surgery describes any surgical procedure involving the mucogingival tissue. It includes surgery which attempts to increase the width of keratinized tissue around a tooth and cover any exposed root surface associated with a recession defect. The main indications for surgical intervention to correct recession defects include the need to improve localized soft tissue aesthetic, or reducing the hypersensitivity, or improving plug control and prevent further progression of the recession defect. So the main indications are as follow. As we see here, we have 4 indications for surgical management of any recession defect. One of them is improving localized soft tissue aesthetic. Second, reducing hypersensitivity. Third, improving plug control. Fourth, preventing further progression of recession defect. Let us jump to the classification of gingival recession. Miller, which is a scientist, a periodontal scientist, has classified gingival recession into 4 categories. These categories can be used to assess the recession defect which is present and predict the possible outcome of any periodontal plastic surgery procedure which would aim to cover the recession defect and restore aesthetic. Defects classified as Class 1 and Class 2 can result in full coverage of the recession defect. Whereas Class 3 would only provide partial coverage to the level of the interdental bone, while Class 4 defects are unlikely to provide any root coverage as a result of surgical intervention, and therefore any periodontal plastic surgery should be avoided. This is commonly seen in patients who have developed recession due to chronic periodontal diseases. So the Class 1 and Class 2 have a good prognosis, while Class 3 is performing partial improvement in the restoring the recession defect, while Class 4 it's hopeless and surgical intervention is unlikely to be done. In Class 1, as we see in the classification, the marginal tissue recession that doesn't extend to the mucogingival junction. This is the mucogingival junction. We have recession, but not extending beyond the mucogingival junction. While in Class 2, the marginal tissue recession that extends beyond the mucogingival junction with no periodontal attachment loss. We have recession here, but without the loss of bone or soft tissue in the interdental area. The interdental areas are intact. interdental areas are intact. In class 3, as we see here, the marginal tissue recession extending beyond the mucogingival junction, with periodontal attachment loss in the interdental area or malpositioning of the teeth. We have loss in the interdental area of the bone and soft tissue here in the class 3. Class 4, marginal tissue recession extend to or beyond the mucogingival junction with severe bone or soft tissue loss in the interdental areas and or severe malpositioning of the teeth. So that's why we have a very bad prognosis in the class 4 for surgical intervention, as we explained in this diagrammatic picture. And this is clinically how the Miller classification is done. Here we see the class 1, in which we have gingival recession not extending beyond the mucogingival junction. Here the recession extending beyond the mucogingival junction but with intact interdental or interproximal area. Here we see the recession extending beyond the mucogingival junction with the interdental bone and soft tissue affected. And here we see that the gingival recession extending beyond the mucogingival line with complete loss of the bone and soft tissue interdentally. So this is how clinically the Miller classification is look like. Here we discuss the factors affecting the outcome of periodontal surgery. There are several factors that can affect the outcome of any periodontal plastic surgery, which we discuss here, and these factors should be assessed and corrected where possible before you do your surgery as a part of pre-surgical preparation or during surgery in order to improve the overall success of the procedure. First, we must consider the condition of root surface, like presence of calculus, caries, contaminated cementum, or restoration on the root surface. We must consider any things like that. Any filling material or caries on the root surface should be removed before surgery, and the root surface should be prepared by scaling to remove any residual calculus and contaminated cementum. Removal of all endotoxins, bacteria, and other antigens found in contaminated cementum is essential to leave the root surface biologically compatible with healthy periodontal tissue. There are many scientists which are highlighted the thorough debridement of the root surface as an essential factor for a successful outcome of periodontal surgery, attempting to provide root coverage over a recession defect. Some authors have suggested the use of citric acid to treat the root surface, to remove the smear layer on the root surface to allow the connective tissue attachment to the root surface. So the conditioning of the root surface by citric acid or EDTA, which we use it in the college, is to allow the new attachment, connective tissue attachment to the root surface. Others have suggested the use of tetracycline hydrochloride to help promote the healing response post-surgical treatment. However, clinical studies have failed to show any improvement in outcome when using such agents. But we prefer, as a periodontist, we prefer the use of these root conditioning materials. The second factors to be considered pre-surgically is a prominent frenal attachment. This can contribute to the cause of gingival recession. Before or as a part of any periodontal plastic surgery, it's worth considering carrying out a frenectomy, complete removal of the frenum to relieve any tension on the gingival tissue. Removing any tension on the gingival tissue here and here from a prominent frenum, which may otherwise result in failure of the surgical procedure. So this is another factor to be considered pre-surgically to get a good surgical outcome. A third consideration is the depth of the vestibule. Depth of the vestibule. This is the vestibule. Patient with a shallow vestibule depth, as we see here, for example, should not be considered for a pedicle graft, as this can result in further decrease in vestibule depth. So alternative surgical procedures should be considered for these patients. So in case of shallow vestibule, we should not use a pedicle graft to correct the situation. The fourth factor is the tissue type. Patient with a thin gingival biotype, as we see here in this picture, are likely to have a poorer outcome than those with a thick gingival biotype. We mentioned in the first part that the thick gingival biotype is less likely to have a gingival recession. So the thick gingival biotype is important and have a good outcome than the thin gingival biotype. It's important to assess the periodontal tissue carefully to see if the gingival tissue requires a surgical procedure, such as connective tissue graft, that will thicken the tissue while also correcting the recession defect. The amount of keratinized tissue available adjacent to the recession defect should also be assessed when considering rotational or coronally advanced pedicle graft. Another factor is the size of recession defect and graft material. The graft material harvested from the donor site should be large enough to cover the whole recession defect. It should be large enough to cover the whole recession defect and extend beyond it in order to get adequate blood supply from the soft tissue surrounding the recession defect. As the root surface doesn't contribute any blood supply to the graft material, recession defects which are narrow result in a better outcome than a wide recession. So a narrow area of recession get a better outcome than a wide area of recession. As the overlap between graft material and recipient soft tissue bed will be greater. The graft should also be of an adequate thickness to prevent necrosis. So the graft thickness should be, we normally take 1 mm to 1.5 mm. In other hand, the height of the recession defect is not as critical as the width of the defect, but it will influence the choice of surgical procedure depending on the amount of attached tissue available and the depth of the vestibule. Another factor which should be considered is the thickness of the split thickness flap raised. The thickness of the flap raised, which will be the covering part of the recession area, the thickness of the raised flap. The split thickness pedicle flap raised for many of the periodontal plastic surgery procedure. It plays an important role in nourishing the grafted tissue. It is essential that this tissue has a certain amount of thickness to be robust enough to fulfill this role. Evidence has shown that flap with a thickness of less than 1 mm can negatively affect the outcome in terms of the amount of root coverage achieved. So the thickness should be within the standards. These are the factors which must be considered pre-surgically before any periodontal plastic surgery. So we end up in the consideration. Now we are going to contraindications to periodontal plastic surgery. First of all, we must know that the smoking, which is the first factor, is a dangerous thing. Any surgical procedure carried out on smokers is likely to have a compromised healing response. So, smoker, take your life. Research has shown that smoking can significantly impair the outcome of surgical periodontal therapy when compared to non-smokers. Periodontal plastic surgery should therefore be avoided in patients who smoke. Secondly, poor oral hygiene. Patients with inadequate oral hygiene and active periodontal disease shouldn't be considered for periodontal plastic surgery. So, bad oral hygiene, despite it affect the oral cavity, it also affect the overall health. If left untreated, dental disease can cause medical condition and even lead to death. So smoking and poor oral hygiene is very significant in taking consideration the contraindications for periodontal plastic surgery. Now we are going to talk about the surgical technique for correcting recession defect. Periodontal plastic surgery is technique sensitive and involves delicate handling of the mucogingival tissues. Scientists concluded that the use of magnification and microsurgical instrument to handle the tissue resulted in improved vascularization of connective tissue graft and increased root coverage compared to macrosurgical technique, which is my opinion too. There are three main types of periodontal plastic surgery procedures described in the literature to treat recession defect. These include pedicle flap, free graft, and guided tissue regeneration. So these three main procedures, pedicle graft and free gingival graft or connective tissue graft and tissue regeneration, are the main three types of procedures used for obscuring or treating the recession defect. Now we are discussing each one in separate. First of all, pedicle graft. A pedicle graft involves repositioning a donor site from an area adjacent to the recession defect, covering this site here from a donor site adjacent to it, like that, to cover the exposed root surface. It avoids the need of a second surgical site and has the advantage of retaining its own blood supply from the base of the flap. It will receive the blood supply from the base of the flap, and it is one surgical site procedure. Just you do surgical procedure in one site, and you don't need to take a graft from donor site from another places in the mouth. So it gains its own blood supply from the base of the flap, which remain attached to the donor site. This helps nourish the graft and facilitate vascular union with the recipient site. The pedicle flap was first described by Groupie and Warren as a laterally repositioned full thickness flap. It's also named previously laterally repositioned full thickness flap. Here the donor tissue is taken from one side and repositioned over the exposed root surface, and this area will be healed with the granulation tissue. This is regarding the full thickness flap. While with the use of split thickness flap, which is later modified by Hattler, he used split thickness flap, repositioned in a similar way that the full thickness flap done, to cover a multiple exposed root surfaces. Soon after, Cohn and Ross described the double papilla reposition flap for use in areas where there was insufficient keratinized tissue. On any one side of the recession defect to reposition and cover the exposed root surface. Here, the papillae are taken from both sides of the recession defect and repositioned over the exposed root surfaces. Like here, as you see, here, this is the double papillary flap. This procedure limits itself to single tooth recession defect, so it can be used for a single tooth recession defect. The papillae or the double papillary flap can also be performed either as a single thickness flap or as a split thickness flap, depending on the thickness of the gingival tissue. Now let us describe the clinical technique for lateral reposition pedicle flap. Before raising the donor tissue, for example here, the width of the recession defect should be measured to gauge what size pedicle flap is required to allow adequate union and healing of the reposition flap. So this width, let's make it in another color, should be measured so as this flap from the donor side will fulfill the recession defect and will obscure the recession area. To allow adequate union and healing of the reposition flap, a cuff of epithelialized tissue around the margin of the recession defect is cut away. Here we cut away the margins of this epithelialized tissue to expose the underlying connective tissue. Similarly, the surface epithelium adjacent to the recession defect on the side opposite to where the donor side will be taken is also removed to expose the underlying connective tissue. Also, we should de-epithelialize this area. We should de-epithelialize the side opposite to the side of the donor. This also should be epithelialized to remove the exposed to remove the epithelium and expose the underlying connective tissue for adequate healing. A pedicle flap twice the width of the recession defect is then raised by making an oblique incision away from the recession defect, leaving a few millimeters, this is the oblique incision, and this width should be twice the width of the recession area, leaving a few millimeters of keratinized tissue, leaving this area of keratinized tissue around the adjacent tooth at the donor side. Then we make a second oblique distal relieving incision toward the apical region from where the first incision is terminated. We do another oblique incision from the area of termination of the first incision. This is, let me show you in more obviously. This is the first incision here till here, and from the end of this incision we made another oblique incision apically. Let me color in another one. like that, and it extends beyond the mucogingival junction into the alveolar lining mucosa, as you see here also in this blur picture. Actually, we made the first incision here and the second incision till beyond the mucogingival junction to the alveolar mucosa. Then we raise this flap and put it over here. So a simple thickness flap is then raised and rotated over the exposed root surface and the connective tissue previously exposed on the opposite side. The graft tissue should be free from any tension. You should free this graft tissue from any tension. This area should be free from any tension. You should release it. If it is not released, the incision should be extended further apically. If you find any tension from the flap, if you find any tension here, you should extend your incision more apically to free the incision and better engage the recession area. Once repositioned, the pedicle flap, it is sutured down with fine interrupted suture and pressure applied for a few minutes to minimize the clot underneath the pedicle graft or the pedicle flap. This is important to ensure a good union between donor and recipient tissue and to ensure a good vascularization of the grafted tissue. Then after that, a periodontal dressing then applied if necessary, but it's not mandatory. The donor site here, this is the donor site, is left to heal by secondary intention. If the flap is left under tension or there is excessive movement and poor stabilization, or if the flap is too narrow for the recession defect, then there's a higher chance of failure of the procedure. So we should be aware about these important things. First of all, stabilization of the flap. Adequate width of the flap. Presence of tension on the flap. So there, in these cases, there's a high chance of failure or higher rate of failure if it's not considered these factor, or if this factor is not considered very well. Secondly, let's talk about the clinical technique for the double papillary flap or rotational flap. This is the double papillary technique. In this technique, the width of the recession defect should be measured initially to ensure that there's a sufficient width of tissue available for the two adjacent papilla to allow a full coverage of the exposed root surfaces. A cuff of epithelialized tissue is removed from around the recession defect to expose the underlying connective tissue from here and here. Split thickness flap of the papillae on either side of the recession defect with a vertical relieving incision on the distal line angle of the tooth in front and mesial line angle of the tooth behind should be raised. Here and here. So one incision is distally and other one mesially is done to reflect the flap from the donor side. The relieving incisions are extended beyond the mucogingival line and taken down to bone at this point to help release tension in the flap. The two papillae are repositioned and placed over the exposed root surface and sutured together with fine interrupted suture. Because this one is separate from that one, we must first suture these papillae with interrupted suture along the midline of the exposed root surface. A sling suture is placed around the tooth to hold the grafted tissue in its position. Here backward, here sling suture to prevent the flap to be displaced apically. Gentle pressure is applied for a few minutes to minimize the clot that forms under the pedicle graft, and a periodontal dressing can be placed if necessary. The exposed connective tissue at the donor side these connective tissues of the donor side is left to heal by secondary intention. Inadequate suturing and inadequate stabilization can result in separation of the two pedicle flap, resulting in failure of the procedure. So, like the laterally repositioned flap, the inadequate suturing can affect the procedure, and inadequate separation of the flap also can make the procedure with a bad prognosis. Another technique for covering the recession area clinically is the coronally repositioned flap. This coronally repositioned flap can be done in one stage to cover a shallow recession defect, or a two-stage technique which is combined with a free gingival graft or connective tissue graft, or with a guided tissue regeneration. If the gingival tissue apical to the recession defect has a thin gingival biotype, or there is insufficient keratinized tissue, a free gingival graft or a connective tissue graft can be carried out. Why? Because first, to increase the thickness and amount of keratinized tissue. So before that, we must assess the gingival biotype, which we talked about in the first part of the recession in my lecture. So if it is a thin gingival biotype, you should consider it, because free gingival graft or connective tissue graft should be combined with this procedure to cover the defect. After approximately 3 months of healing, the tissue can be coronally repositioned as a second stage surgery. But if the keratinized tissue or the gingival tissue is of the thick biotype or thick gingival biotype, which is at least should be 3 millimeter in thickness, then the tissue can be coronally repositioned as a one-stage technique. In order to carry out this procedure, it's essential to ensure that there are shallow crevicular depth on interproximal surface and no interproximal bone loss. The amount of coronal advancement required is determined by measuring the height of recession defect. The same length is then measured from the tip of the papillae toward the apex, and horizontal incision are placed through the tissue for a split thickness flap. So a horizontal incision here and here is made for doing a split thickness flap. Then a vertical incision here and here is done. Vertical relieving incision are placed at the distal line angle of one tooth anteriorly and medial line angle of one tooth posterior to the tooth where the recession defect is present. A split thickness flap of even thickness is raised and extended beyond the mucogingival margin. The periosteum is released to allow freedom of movement of the flap. The most coronal part of the papillae, which remain intact, is deepithelialized before coronal advancement of the flap. This area, I'll show you. This area should be deepithelialized before coronally advancing the flap to ensure a good attachment with the connective tissue. The flap is then sutured in place approximately 0.5 mm to 1 mm coronal to the cemento-enamel junction with interrupted suture in the papillae region and along the relieving incision. Gentle pressure is applied for a few minutes, and if necessary, a periodontal dressing can be placed. Excessive tension in the coronally advanced flap can result in failure or a reduced amount of root coverage. Finally, I would like to describe or explain the prognosis of this surgical procedure. Usually, the periodontal plastic surgery has been shown to be effective in reducing gingival recession defect, with a concomitant improvement in attachment levels. Achieving full root coverage following a single periodontal plastic surgical procedure is difficult, and success is often considered to be any decrease in amount of exposed root surface. That's to say, an increase in gingival height from the mucogingival line to the gingival margin. The size of the initial recession defect will also influence the final outcome. A recent systematic review found that overall, a better percentage of a complete and mean root coverage has been in increased defects less than 4 mm. The mean root coverage achieved with a laterally repositioned flap and the double papilla flap have shown to be vary between 34 to 81%, and complete root coverage varies between 40 to 50% of sites. With these procedures, there is a risk of donor side recession, particularly with the laterally repositioned flap of approximately 1 mm. The mean root coverage achieved with a single stage coronally repositioned flap varies between 55 to 99%, and complete root coverage range from 24 to 95% of sites. One of the scientists concluded that in order to achieve 100% root coverage with a coronally repositioned flap, the flap should be overcompensated by 2 to 2.5 mm and suture tension free. This may be difficult in cases where there is a large recession defect and a shallow sulcus depth. The coronally advanced flap is often used together with a subepithelial connective tissue graft and has proven to be the gold standard treatment in the treatment of recession defect. So the coronally repositioned flap plus the connective tissue graft is the best treatment for a recession defect. In Miller class 1 defect, this combination has shown to provide complete root coverage of the recession defect. In brief, and as a conclusion, gingival recession can be corrected using pedicle graft, but careful case selection is essential for complete root coverage. To ensure success of periodontal plastic surgery, several patient and tooth-related factors needed to be assessed before surgery. Pedicle grafts are not suitable in cases with thin gingival biotype and in areas where there is a lack of keratinized tissue. This is the end of my lecture. Thank you for your listening, and wait for the third part of the gingival recession.